the infection. There's other things that can potentially lead to that. But anytime you see something and you know there's a source of trauma, you have to consider traumatic ulcer. How about this one? Good. So recurrent after stomatitis minor. Okay. That's okay if you mix up your words. It's okay, but as long as you have minor and after stomatitis, all of those words in your answer. Okay. What is your diagnosis for these lesions? It's peroxide burn. So you have to write down peroxide and burn, both. And remember, again, we talked in class, anytime you talk about, burns, chemical burns, you have to indicate the product that's actually causing the burn. Okay? Yes?
Chemical peroxide burn.
Just want to make sure.
Why are you so specific?
Question number 4. The critical thing is, are you recognizing the process, and do you have a diagnosis, to go along with it? Right? So what is your diagnosis for this one? Angioedema. Okay? How about this one? Contact stomatitis.
Oh, damn. Okay. Yeah. I thought it was, it was chewing gum.
Do you guys have any questions? That's Dr. Richard's topic, and she'll be available next week, so you can discuss. But the correct answer for that is contact stomatitis. What is your diagnosis for this? What's your treatment for this? No treatment. That's what I'm looking for, because this is linea alba. And again, we talked about it in class. We said when you see linea alba, you just document it, let the patient know. No treatment. If they have higher functional habits, and if you wrote down quit higher functional habits, I'm okay with that too.
I couldn't see the phone.
Ideally, that's not appropriate because I'm specifically asking for a treatment and not diagnosis, but I will review your answers and see what I want to do with it. But that's not what we're expecting. You have to be, if the question asks for a diagnosis, you guys have to write down diagnosis. If it asks for treatment, it's treatment.
But you can't use. Which one? Recurrent after stomatitis? No, the clinical presentation of that is most consistent with a minor. That's usually how they present. That's the most common site. That's not, I don't think there's any much discussion that we can do with that. It's pretty straightforward. But this
what about this one? Petechiae, okay? So, if you see here, basically I asked for a specific diagnostic term, and we said that again in class. If I ask for what is the process, then you can say submucosal hemorrhage. But the diagnostic term, each of these entities have different diagnostic terms that they go by. If you looked at this area, and if you consider purpura, that's fine too, but basically what happened is this merging of the petechiae to form a larger area, but it's actually a petechial hemorrhage. Yes?
So the difference between cause and diagnosis? It's like the wording is so...
Okay, I'll have to review our answers. If you had two, and I specifically said it's a specific diagnostic term. So when you guys start, elaborating your answers, it's hard for me to tell, where you're going with it, right? So if there's a specific question and a specific answer associated with that, you guys need to focus on just on that. Yes?
Submucosal, acute hemorrhage, and then hemorrhage is
Be specific when there's a specific term that goes for it, right? Submucosal hemorrhage is more of a general description of the process, but the term that actually describes it is petechiae. But I will review our answers and I'll decide what I want to do with it. Okay, so let's look at your written questions. So contact stomatitis is an immune-mediated oral disease involving hypersensitivity mechanisms. which specific type of hypersensitivity reaction produces contact stomatitis? Type 4. Correct. Okay, stress is one of the most common things that is known to trigger an episode of recurrent after stomatitis. Other than stress, what is one more well-known trigger for recurrent after stomatitis? Trauma, okay. Chemicals, okay. Food, okay. So any of those, as long as it's within the spectrum of things that can potentially trigger, cause these, you're okay with it. Okay. The last question is submucosal hemorrhage represents entrapment of blood within the tissues. What diagnostic term best describes a mass that's formed due to this blood accumulation? Hematoma, because it's a mass, it's a hematoma. Okay.
You guys are so smart.
So, we're going to continue with our lecture.
I'm going to put
I know a couple of you have to go move your cards. Go ahead, do that, and then come back because. Okay. That doesn't mean you get to skip the class. Just move your cards and you come back. Looks like there's some funeral or something that they have to. We got messages. Okay, guys. So we're not going to take a break because we took the 10 minutes up front. So we're going to continue with that topic, neoplasia. This is a topic that's going to be on your section exam for general pathology. This is a general path topic, neoplasia. Okay? So, yes. No, it's not on class. So if you guys want to record it, then go for it.
Yeah, Brad, you got that YouTube? You're good.
Okay, let's settle down. Okay, so we're going to talk about neoplasia. So there's a lot of terms that we're going to talk about today. And basically you need to familiarize yourself with what these terms actually mean. So when you come across this description, then you know what we're talking about. So let's start off with the more basic ones, right? So we have what's called hypertrophy and hyperplasia. Do you guys know the difference between hypertrophy and hyperplasia? Yes. What is the difference? So hypertrophy is increase in the size of the cell, whereas hyperplasia is actually increase in the number of cells. So if you look at this one, if this is a normal cell, and then look at the size of the cell. It's almost doubled or tripled in size, right? So if you see a cell that's much larger than what a normal cell should look like, you call it a hypertrophied cell, okay? If you have a cell, typically if you're supposed to have 5 or 10 cells in an area, but you start seeing like maybe 20 cells in that area instead of 10, then that means there's hyperplasia. There's more number of cells than what you should normally see in that area. So that's called hyperplasia. And this is an example of something that's both hypertrophy and hyperplastic, right? So you have cells that are increased in size and they increased in number. And these are critical things to remember because when you look at neoplasia, so when you look at a tumor, right, whether it's a benign tumor or malignant tumor, there's alteration in both the size of the cells and there's alteration in the number of cells. Okay, so hypertrophy and hyperplasia are two terms to remember when you look at these. Okay, so what is metaplasia? Metaplasia basically means one cell type is replaced by another cell type. Okay, a good example for that is someone who smokes. Okay, so what happens is in a smoker, there's actually change of the epithelial subtype. Okay, so from a squamous epithelium, it turns into a different kind of epithelium, which is basically because of inflammation in that area. Okay, or vice versa. So for example, if you're looking at lungs, right, what kind of epithelium do you think lines the lungs? Respiratory epithelium. So when you say respiratory epithelium, what does the cells look like? What do the cells look like? So they're ciliated, right? And they are stratified and they are columnar, okay? And then from a respiratory epithelium, if it transitions into a squamous epithelium, that's not good. Why? Because this increases the risk for malignancy. Okay, so a transition from one cell type to another cell type. So this is called a ciliated epithelium, because if you look at the top of these cells, you see these little tiny structures that are kind of projecting. So those are your cilia. So that's why we call them ciliated. Okay, and this is basically columnar epithelium. So it's not short cells; they're really elongated cells. Okay, so when you see elongated cells that have cilia on them, they call them ciliated columnar cells, right? And then they're transitioning into these squamous cells, and this process of transition is called metaplasia. Okay, so, and that's not a good thing. When you see something becoming metaplastic, we get concerned that, you know, it's going to transition into some kind of, neoplasm. Okay, so what does the term dysplasia mean? So dysplasia basically means disorderly growth. Okay, so that means what you see in these dysplastic cases is the cells, they don't look like each other anymore. They start looking different from each other. When we look at hyperplasia and hypertrophy, do the cells look like each other? No. Yes, they look like each other, but they just increased in number or they increased in size. Okay, whereas in dysplasia, they not only increase in number, increase in size, but they also start looking different from each other. Does that make sense? Okay, so dysplasia basically means it's a precancerous change. Okay, so there's different grades of dysplasia. You have mild, moderate, and severe. Okay, so the one that's on the top left, that's a normal epithelium. The one that you see in top right, this is called mild dysplasia, because what you see here, when you look at the outline of that dysplastic area, it's only in the bottom 1/3 of the thickness of the epithelium. Does that make sense? So if the dysplastic changes are just localized to the bottom 1/3 of the epithelium, then you call it mild dysplasia. But if it affects about half of the thickness of the epithelium, then you call it moderate. But if it affects more than 2/3 of the epithelial thickness, then you call it severe. Okay? If it affects the entire thickness of the epithelium, so if every cell in that epithelium looks different from each other, if every cell looks really enlarged, if every cell looks really dark, and then, and it's, this changes throughout the entire thickness, that means it's carcinoma in-situ. So the reason what happens is in carcinoma in-situ, you look at these cells. Does that epithelium look normal to you guys? What's abnormal about it?
Organization.
I'm sorry?
Organization.
Organization, right? So it actually looks like the cells are basically, so epithelial cells, they usually are kind of parallel to the basement membrane, this area right here. But here, if you look at it, they look perpendicular, right? They're going all vertically, rather than going horizontally, the cells. So there's a lack, in proper organization of cells here, okay? And then, if you look at each of these cells, what do you see here? See something that looks really dark, right? This is a mitotic figure. And this is not a normal mitosis. This is abnormal mitosis, okay? So if you start seeing these abnormal mitotic figures, and look at the cells, do they look like they resemble each other, or they look different from each other? They look different from each other. So each cell, this one looks pretty large, this one looks small, this one looks a little bigger, this is much bigger than these, and this one is, looks like it's clumping together, okay? So they all look different from each other, right? And this change that you're seeing is throughout the entire thickness of the epithelium. So from the bottom of the epithelium to the top, you see these changes, okay? So this is called carcinoma in-situ. The reason why this diagnosis is critical is because if these abnormal cells break through this membrane that's separating it from the connective tissue, then it turns into cancer. Does that make sense? So as long as it stays within the epithelium, you just call it carcinoma in-situ. That means there's no invasion into the connective tissue. The moment it breaks through the basement membrane and goes into the connective tissue, that's bad news, right? Because then it becomes squamous cell carcinoma at that point. You had a question?
So the in-situ is lack of the invasion?
Yes.
But then once it's invaded, it's cancer.
That's right. So if there's no invasion and if the changes are just restricted to the epithelial layer, but it's throughout the entire thickness of the epithelial layer, then you call it carcinoma in situ. Okay? If the changes break through the basement membrane and then get into the connective tissue, you call it squamous cell carcinoma at that point. Okay, so it's critical. So if I ask you what does carcinoma in situ mean, you have to say the changes that are affecting the entire thickness of the epithelium without invasion. That's the critical thing, is the word lack of invasion.
And in situ.
That's carcinoma in situ. That's right. So in situ means it's within, right? So it's not going beyond where it's supposed to be. So the terms that we talked about so far are hyperplasia, hypertrophy, okay? We talked about metaplasia, and we talked about dysplasia and carcinoma in situ, right? So what is hypertrophy? Increase in the size of cells. What is hyperplasia? Increase in the number of cells. What is metaplasia?
Epithelial change from one type to another.
So it's change of one cell type to another cell type. It could be ciliated to squamous, it could be squamous to columnar, it could be anything, but one cell type changes to another. That's called metaplasia or metaplastic change. Okay, what is dysplasia?
Irregularities.
So disorderly growth, right? So in dysplasia, are there different grades of dysplasia?
Yes.
Yes, what are the three different grades?
Mild, moderate,
Mild, moderate, and severe. Okay? Mild means the changes are just restricted to the lower 1/3 of the epithelium. Moderate means it's the half of the epithelial thickness. Severe means about 2/3. And if it involves the entire thickness of the epithelium, what do you call it?
in situ.
Carcinoma in situ. Okay? And do you have invasion in carcinoma in situ?
No.
No, and that's a critical thing to remember. Okay, so the other terms are, now we're moving on to neoplasia, right? What does neoplasia mean? Neoplasia means it's new growth. Okay, so what happens in this new growth? There's both abnormal and uncontrolled proliferation of cells. So the cells not only look abnormal, that means they look bigger than what they're supposed to be. They are darkly staining than they're what they're supposed to be. They have these mitotic figures that don't belong in there. So that's your abnormal cells. Not only do they look abnormal, but they are proliferating. That means they're multiplying uncontrollably, right? So neoplasia, you not only have abnormal cells, but you also have an uncontrolled proliferation of these cells.
Isn't that cancer?
Not every neoplasia is cancer. Neoplasia means tumor, basically. So it can be benign or malignant. Okay, so you can have a benign neoplasm or a malignant neoplasm. But basically what it means is that the cells are growing at a rate that they shouldn't be doing. Okay, and they look different from what they should normally look like. So neoplasm means, so neoplasia is the process, right? So that means you have this abnormal, uncontrolled proliferation of cells. If that process leads to formation of a mass, then we call it neoplasm. Okay, so neoplasia is actually the mechanism, and neoplasm is what's the end result of that mechanism. Okay, so neoplasm is basically a mass, and that's abnormal cells. So neoplasm and tumor, if you look at the literature, they use that kind of synonymously. So they interchangeably they use them, those two terms. And when you talk about the word oncology basically means you're studying these tumors or neoplasms. Okay, so they can be benign or malignant, but oncology refers to the study of tumors. Okay. So then how do we differentiate between something that's benign versus something that's malignant, right? So now you have both of them are abnormal growths. Both of them have uncontrolled proliferation of cells, and they both can form a mass, right? But there has to be subtle differences between those two to help us, because we don't want every patient who walks in, you see a lump, you tell them, oh, you may have cancer. You don't want to do that, right? Because that really stresses them out. Like, unfortunately, I had one patient yesterday in my practice who knew coming in that it's going to be malignancy. Because if you look in the inside of his mouth, he had this really fungating mass in the floor of the mouth. It almost looked like a flower. So if you look at it, it had this, the petals of a flower. So the outside of it looked like that, but if you look at the inside of it, it was all necrotic, and he was in excruciating pain. And unfortunately, this patient said, this grew to this size, within like few weeks, right? And he knew coming in, thinking that he's going to have, he's going to get a diagnosis of malignancy, right? So in patients like that, you have to approach with caution. He was really nervous, really stressed out. But again, in a patient like this who's aware of what's going on in their mouth, it's easier to get that diagnosis. But then if you have someone who comes in who's not expecting that kind of a diagnosis, you don't want to tell them that they have something in their mouth that could potentially be malignant if it's not. Does that make sense? Right? Because it stresses them out. It puts you in a very uncomfortable zone when you're dealing with this, later on. So you want to learn about different ways that you can differentiate between these two things, benign versus malignant. So benign basically means histologically. So if I took a biopsy of a mass, right, and if I want to call it a benign lesion, it has to be a very well differentiated lesion. So that means it has to look like the area of the normal cells in that area. Does that make sense? So the tissue of origin. So for example, if you're looking at a benign muscle tumor, right? It has to look like muscle. The cells of it look like muscle. It's just that there are too many of them, and they're of all different sizes and shapes. Okay, but at the end of the day, I should be able to still recognize it as a muscular tissue, okay, or a nervous tissue, or vascular tissue. I need to be able to recognize what is the origin of that. Okay, so they usually tend to be well differentiated. Malignant neoplasms, on the other hand, can be well differentiated, or they can be on the complete opposite end of the spectrum, and they can be anaplastic. Anaplastic means they lose differentiation. So sometimes when you look at diagnosis, right, from the pathologist, they'll say that it's a poorly differentiated squamous cell carcinoma, right? So that means we cannot really for sure, look at any features in that, sample and pinpoint and say that this is epithelial in origin, because it just looks really ugly, unfortunately. Okay, and the problem with that, it's just not the appearance of it, right? The thing is, the prognosis is poor. So if you have something that's poorly differentiated, and if it's anaplastic, that means it loses its differentiation and does not mimic the cell that it's arising from. The prognosis for that patient is going to be bad, because they have really aggressive lesions at that point. Okay, does that make sense? So benign neoplasms usually tend to be slow growing. So when you talk to a patient and you take a history, you want to find out how long they've had that for, right? So if they tell you they've had it for 6 months, 8 months, but it's gradually increasing in size, then the likely possibility is that it's more likely to be a benign process. Again, going back to the example that I had from yesterday, right? That patient told me that doubled in size in a few weeks' time. Okay, that's usually not a sign of something that's benign process, especially when it looks like that in the patient's mouth. Okay, malignant neoplasms, on the other hand, are it's a spectrum, right? Some of them can be slow growing, but a lot of them tend to be rapidly growing lesions when you look at malignancies. Malignancy and cancer is kind of synonymous. Okay, so you use the term carcinoma if it's epithelial in origin, and we'll go over that a bit later on. Yes.
Can we move back up when you said benign neoplasms are usually well differentiated, and then malignant is well differentiated to anaplastic? What is anaplastic?
Anaplastic means there's a loss of differentiation. So that means when I look at it under the microscope, I cannot tell you what is the site of origin for this tumor. Right, what is the tissue of origin? Is it epithelial in origin? Is it nervous tissue in origin? Is it muscular origin?
So totally different.
They look very different, and they look really as if they're completely disorganized. They look really big. They look very different from each other. So they don't have the characteristic features of the tissue of origin that they need to have. And I'll show you some examples histologically what it looks like. Okay, so. Again, if it's a benign neoplasm, they usually, you typically don't see mitosis, so they're usually not as proliferating as a malignant neoplasm. Malignant neoplasms, they tend to multiply very fast, and that's why they're rapidly growing, right? Benign neoplasms usually don't multiply as quickly, they're slowly growing. And benign neoplasms usually have a capsule around them, okay? So basically what happens is you'll have a fibrous tissue that gets compressed,
and then it forms like an outline around these masses. Okay, so that's called a capsule. When you see a capsule, that's a good thing. Okay, basically that means you can scoop out the tumor in one piece, typically, because it's nicely contained within this, capsule, right? So they usually tend to be well circumscribed. They tend to have this capsule around them, whereas a malignant neoplasm obviously is not going to have that capsule, right? Because it's actually now breaking through, the epithelium and then going into the connective tissue. Or it could be just in the connective tissue without any borders around it. Okay, so a benign neoplasm typically does not metastasize. Do you guys know what metastasis means?
Spreads.
Spreads, right? So it spreads from the site of origin. So if a patient has a lesion in the jawbone, for example, right? But then you notice that there is a lump in patient's lungs, okay? And it looks the same as what they have in the jawbones. If you do a biopsy, if they look similar to each other, then that means the tumor has metastasized. So it went from the patient's jawbone into the bloodstream and gone into the lungs. Okay? Or it can go into the lymph nodes, which is the most common site, especially in the jawbones and maxilla and mandible. One of the most common sites that tumors can metastasize to is actually in the cervical lymph nodes, so in the neck. And that's why it's critical. When you guys do a head and neck examination, we always emphasize, please palpate, for any palpable lymph nodes. Because sometimes it could be a sign of, an underlying disease process. It could be inflammatory, it could be neoplastic, but you need to make sure that you're doing a thorough examination because that helps staging the tumors, what stage they are at when you do these lymph node exam. Yes? Someone had a question.
So what was the rare mitotic figures?
So mitosis is basically is really abnormal looking cells that indicate how quickly the tumor is proliferating, how quickly it's multiplying and growing. So typically, if it's a benign neoplasm, you don't tend to see these mitotic activity, right? So it's not proliferating as much as what a malignancy would do. Okay, and then the mitotic figures, they also don't look like normal mitosis because normally we all have mitosis, right? Because cells continuously replicate in our body, they die and then new cells come about, right? So, but if those start looking, different from each other and they start having different shapes to it, then that's an abnormal mitotic figure, and that's not a good sign when you see abnormal mitotic figures. Okay, so. So metastasis is basically means, did it go from its site of origin to a distant site? Okay, so, and typically if it's a benign tumor, you don't see metastasis associated with that, right? They're just in the area where you notice them. But in a malignancy, there's a likely possibility of metastasis, and that dictates the staging of the disease. Usually benign tumors are not life-threatening, but malignancies tend to have mortality associated with them. Okay, so how do you differentiate between a benign and a malignant? You have to look at the features, the cell, right? So is it well differentiated or is it poorly differentiated? Okay, what is the type of growth, the mode of growth? Is it slow growing or is it fast growing? Okay, what is the rate of growth? And then how are the cells differentiated, which is the same thing as cellular features? Does it have the ability to metastasize? Does it have the ability to recur? Does it come back? And then what is the mortality rate? Okay, so whenever you look at, so you have hyperplasia, you have hypertrophy, metaplasia, dysplasia, carcinoma in-situ, neoplasia, and then we talked about benign and malignant neoplasms, right? So can you guys give me a couple of things that you can look for to differentiate between a benign and a malignant neoplasm?
Is it encapsulated?
Which one is capsulated?
Benign.
Benign, okay. Give me another one.
Growth.
Growth. What type of growth?
Slow.
If it's slow growing, what does it typically indicate?
Benign.
Benign process. If it's rapidly growing,
Malignant.
more likely to be malignant. Okay, so you need to know that differences between a benign neoplasm and a malignant neoplasm. So whenever you look at a neoplasm, you're looking at two areas in a tumor. Okay, you're looking at what's called parenchyma, and then there's another area called stroma.
So parenchyma is basically the main meat of that lesion, right? So that's where you have all these neoplastic cells. And then the parenchyma, the neoplastic cells, are the ones that, kind of determine what kind of behavior is this tumor going to have. Then you have a stroma. So stroma is basically all the other stuff that surrounds the neoplastic cells. It's kind of a supporting tissue. So that means it's going to have blood vessels. One of the things we talk about whenever you talk about a malignancy is they have something called angiogenesis. Okay, does that mean something to you guys when I say angiogenesis? What does that mean?
Making blood vessels.
Making new blood vessels, right? So you need to have lots of new blood vessels next to a tumor for the tumor to grow, right? So your stroma is the one that contains these blood vessels. Make sense? So you have the main meat of the tumor, which is your parenchyma, that's made up of all these tumor cells or neoplastic cells, and then supporting that tumor is your supporting tissue or the stroma. Okay, and then the stroma is the one that actually contains the blood vessels or any kind of inflammatory cells, because anytime you have something that's foreign in the body tries to protect it, right? So you have an influx of these inflammatory cells that come into the area to fight off that, right? So you're going to see these inflammatory cells, new blood vessels that kind of help feed the tumor, all of these sitting in the stroma. So far so good? Okay, if you guys have any questions, stop me, okay? And then we can kind of review the areas. So when we look at parenchyma, right, so which is the main meat of the tumor, which is made up of these neoplastic cells, this is where the term differentiation is used, okay, because we're actually looking at these tumor cells. And then we're trying to figure out what is the extent to which this tumor, the cells of this tumor, actually resemble the cells from which they originate, right? Because you have different kind of tumors. You have tumors that arise from blood vessels. You can have tumors that arise from nervous tissue. You have tumors that arise from muscle, smooth muscle, skeletal muscle. You can have tumors that arise from fat. You have tumors that arise from epithelium. So there's many tumors, many sources of origin for different tumors, right? So when you talk about the term differentiation, basically what we are trying to say is you look at these tumor cells, and can you tell by looking at these tumor cells how much they resemble the cell of origin? Okay, both morphologically, that means looking at it structurally, as well as functionally. So both ways, how much does it resemble? So if you're saying a well-differentiated tumor, what does that mean to you guys? Is it going to look more similar to the cell of origin, the neoplastic cells, or is it going to look different from the cell of origin? Similar, right? So well-differentiated tumor, neoplastic cells resemble the normal cells or the cells that it originates from. If it's a poorly differentiated tumor, they only have very few features that resemble the cells that they originate from. Okay? If it's an undifferentiated tumor or an anaplastic tumor, they do not resemble the cells from which they originate, right? And those are extremely hard to diagnose, unfortunately. So what we do as pathologists is we do some special immunohistochemical stains on a sample. So if I get, let's take an example. So you have a patient who walks into your office, you see a growth in their mouth, okay? Then you decide this growth does not look nice. This is a tumor, right? But you don't know if it's a benign tumor or malignant tumor. So you're going to apply the features that you have learned, how to differentiate between the benign and a malignant tumor. And then tentatively say, okay, this looks more like a malignant tumor because it appears to be rapidly growing. It does not look, very pleasant to look at, okay? And then it seems to, and then you're able to palpate some lymph nodes, for example, okay? So that's your scenario. Now you decide you want to send this to an oral surgeon. So the patient goes to the oral surgeon, they go ahead, do the biopsy. And then once they do the biopsy, once they collect the tissue sample, they basically fix it in formalin. So you get these formalin containers, they put the specimen in formalin, and then they send it to the pathologist. So once it comes to me as a pathologist, what I'm going to do is basically cut slides. Okay, so put this sample in paraffin wax, and then I'll cut samples and then make slides from it, right? And then I'm going to look at it. When I look at it,
if I'm able to look at the cells under the microscope and then definitively say, hey, looks like it's a muscle tumor, or looks like it's a nerve tumor, that means it's a well-differentiated tumor. So I can look at it and then I can tell you what tissue it originated from, right? But sometimes I won't be able to do that. So then we do what's called immunohistochemical stains. So we take these special stains that are tagged for the cells that they originate from. So like a nerve tumor has a stain that we call S100, for example. If it's a melanin-based tumor, like a melanoma, we do what's called HMB45. Okay, so we take that special stain and then we basically, stain that tissue on the slide with the special, immunohistochemical stain, right? It's a process that it goes through. I'm trying to kind of simplify it. Once we do that, then we look under the microscope and then say, did it look positive or negative? If it lights up with that S100, then I know that it's a neural origin, because just looking at it under the microscope with routine H&E staining, I cannot tell. That's why it's an anaplastic tumor, right? But then by doing that special stain, now I can tell, okay, this is nerve origin or smooth muscle origin or skeletal muscle origin, right? So anaplastic tumors, unfortunately, pose a really bad problem for pathologists, like to make diagnosis, because they don't resemble the cell of origin. Okay, and the behavior for the patient, unfortunately, is also these are aggressive tumors. Okay, so if you look at this one, right? So you have a tumor that looks like this. Now, let's look at some of the features here. So what does this look like to you guys?
Benign.
Does that look pink?
Yes.
Okay. Does it look like it's in like a swirling pattern? Okay. Does it look like it has any nuclei in it? No, it just looks like pink lines kind of swirling, right? Okay, so that's called keratin. Okay, so when you see keratin, what is keratin typically associated with? What type of cells?
Epithelial.
Epithelial cells. So when I see that and I see that it's forming those swirls, in the tissue, I know this is epithelial in origin, because that's pretty much the only cell type that keratin is associated with. Okay, so we call it a squamous cell carcinoma, right? Because it actually broke through the membrane on the top. Let me see if I can connect this and what's the pointer? Okay, so if you see here, you see how that's the epithelium. Now you have a break here, right? You don't see the epithelium anymore, and you start seeing these cells kind of going into the connective tissue. We know this is connective tissue because you see all these blood vessels right here. So now it broke through the epithelium, went into the connective tissue. So would we call this carcinoma? Because it's not in the epithelium anymore, right? It's in the connective tissue. So we call this carcinoma, right? So this is a squamous cell carcinoma because it's arising from the epithelial cells. That's why it's called squamous cell carcinoma. Okay? Now it went into the connective tissue. Now I look at each of these individual cells and then try and figure out, is this epithelial in origin? Is this muscle in origin? Is this nervous tissue in origin, right? And I know that this is epithelial in origin because I'm seeing these keratin pearls. And then I see these cells that look like epithelial cells, but they're just really not, good to look at. Okay? So that's basically, how you get to a diagnosis, right? So if I see this, I would call this a well-differentiated squamous cell carcinoma because I can tell you for sure that this is epithelial in origin, this malignancy. So that's how you apply that differentiation, the terms. So when I look at this one, I can look at these cells and they look like epithelial cells, but they're staining really blue, right? So they're much more basophilic. They do not look like the previous example that we've seen, right? And do you see keratin pearls? No. So I don't see keratin pearls, so I can't be 100% certain, right? But then I start looking at the cells and I'm like, oh, the cells look more epithelial in origin. They're mimicking the epithelial cells. It's just that it doesn't have all of the other features of epithelial origin like keratin pearls and stuff. So I would call this moderately differentiated, right? So it still resembles the cell of origin, which is the epithelium, but it doesn't have all of its features. So that's why this would be a moderately differentiated.
Now if I see this, do you see any keratin pearls here? Can you even tell? So this is the area that looks like it's malignant, right? Because the cells are really darkly staining. Okay, if you have a nucleus that's much bigger than what it typically should be, okay, the cells look different from each other. But then you start seeing here in the connective tissue, do they look like epithelial cells? These cells right here?
Slightly, yeah.
No, it's hard to tell because they're kind of elongated, right? And epithelial cells are typically not elongated. They're more like, polygonal in shape, right? So if you see here, they're starting to lose their architecture, okay? So there's some resemblance, but it's not all of the cells don't have that. So this would be a poorly differentiated tumor, okay? And then an anaplastic tumor, you won't even be able to tell that it's epithelial in origin. Right? It's just every cell is going to look very different from each other, and it doesn't have good differentiation. Yes.
I have a question. So on the test, would you bring these pictures and ask us which one it is?
You don't need to worry about histology. It's just basically to learn about the process. What does the term? Because when you hear the term, but you need to know what all of those terms mean. Differentiation. What does the term differentiation mean? And you need to know what are the different, types of differentiation: well differentiated, moderately, poorly, and then, anaplastic with no differentiation. But this basically kind of explains why you see those changes. Why you call it what it is. Yes.
For the other lectures, there was for each physical or chemical injuries, there was histology thing.
If I specifically mention in class that you need to focus on histology, then you need to. But otherwise, don't worry about the other entities. So, for example, if you're looking at skin diseases, and if I told you that you need to know histology to differentiate between 3 entities, like pemphigus vulgaris, pemphigoid, and lichen planus, you need to know the histology. Okay, but if I didn't mention in class that that's critical for you guys, don't worry about histology. It's more for your, understanding the disease process, more than anything else. Okay. So what are the features that you see in these malignant cells? So you see, so when you look at a neoplastic cell that's malignant, the things you need to look for is it pleomorphic, right? What does the term pleomorphism mean? Means there's variability in the size of cells and shape of cells. So that means each cell looks different from an adjacent cell, okay? Both in size as well as in shape. And then these neoplastic cells or malignant cells are going to show abnormalities or changes in the nucleus, okay? So what does the nucleus look like? If you look at the previous example, you can see how the nuclei look much darker staining than what a normal cell would look like, right? So that's called hyperplasia, okay? And then you can have variability in the size of the nucleus, the shape of the nucleus, and then also nuclei they're going to have another structure on the inside called nucleoli, okay? So a neoplastic cell or a malignant cell is going to have multiple nucleoli sometimes, okay? And then also because the nucleus is so large, and then, so what happens to the nucleus cytoplasmic ratio? Exactly, so it becomes 1:1 rather than 1:4 or 1:6. Typically, your cytoplasm should be more, and your nucleus should be a small, area in the cell, right? But in a neoplastic cell or a malignant cell, that ratio gets altered. Because the nucleus gets enlarged, the ratio between nucleus to cytoplasm almost becomes 1:1. Because you have a really large nucleus and now less cytoplasm. Okay, and then this loss of polarity. So remember when we looked at one of these pictures here, let's see. So I said when you look at this example right here, we said the cells, they're not parallel to the basement membrane like the way they should be, but they're oriented pretty much perpendicular to the basement membrane. Okay, so that's called loss of polarity. Okay, so that means they lose their normal orientation, these neoplastic cells. So that's called loss of polarity. So it's important. The reason why this topic is important is because you're going to hear these terms when we talk about epithelial pathology and squamous cell carcinomas and malignancies or precancers. And then all of these terms would make more sense when you actually, look at it, when you have that clinical application and actually look at a lesion in a patient's mouth, when you hear these terms, this is what it means. Okay. And then you can have normal and abnormal mitotic figures. Okay. So if you guys look at this, would you consider these normal cells? What's abnormal about them? Okay. List it for me. What's everything? Okay, one at a time. Let's go with what's the most prominent thing that you guys see here?
Hypertrophy.
Okay, so there's hypertrophy. Looks like they're enlarged in size. Okay, what else? You said multinucleated, right? So it looks like it has multiple nuclei. Is that a feature that you normally see with a regular cell? No, you're supposed to typically see one nucleus per cell, right? So it appears multinucleated. What else?
Different shapes.
They're of different shapes, right? So they're different sizes and they're different shapes and they're enlarged in size, okay? And they have multiple nuclei. Anything else? You have abnormal mitotic figures, okay? So there's some mitosis right here. It's hard to tell, okay? But this is a mitotic figure right there.
Multiple nucleotides.
So it looks like it's being pulled. So it could be in different phases, like prophase, telophase, So they can be in different phases of activity. What else?
Multiple nucleoli.
Multiple nucleoli, right? If you look at the nucleus, it actually looks like it has some inclusions in them. And these are nucleoli. So these are the features that you're looking for when you're looking at a neoplastic cell. If you look at this, would you consider neoplastic?
Yes.
Right, because it's an abnormal disorderly growth here. Okay, would you consider this benign or malignant? Malignant, right? Because the cells now, they look very different from each other. They're enlarged in size. They have increase in the number of nuclei, number of nucleoli. The cells are, they don't. I can't tell you looking at this what is the site of origin. What tissue is it originating from? Because the cells look so different from each other. Okay, so these are hard ones. So would this be an anaplastic tumor? Yes, right, because this lost its differentiation. So it does not resemble the cell of origin. Okay, this is another example. Okay, what is this one right here? That's a mitotic figure. Okay, so that's an abnormal mitotic figure that you're seeing in what looks like a neoplasm. Again, same features, right? You have some cells that have multiple nuclei, multiple nuclei, multiple nuclei. You have mitotic figures. The cells don't look, similar to each other. They're very different from each other, right? And they are, enlarged in size. So they're hypertrophied. They're hyperplastic. You have more cells than what you should normally have. Okay. So all of these again are not good features. Okay. So then we look at. So remember when we said whenever you look at a tumor or a neoplasm, there are two areas that a neoplasm has or a tumor has. One is your parenchyma and then the other one is the stroma, right? What does parenchyma contain? The main tumor, the neoplastic cells, right? What does your stroma contain? The supporting tissue, so your blood vessels, inflammatory cells, and all of those things come right in the stroma. So the stroma does not help to differentiate between a benign and a malignant tumor. It's actually the main neoplasm is the one that actually differentiates, right? But then the consistency of what a tumor feels like when you palpate it is actually determined by the stroma. Okay, so if you have a lot of collagen in the connective tissue, in the stroma, surrounding the tumor, when you palpate it, how does it feel? It's going to feel firm, right? It's going to feel hard. So if it has more of these adipose tissue, like fatty tissue in that area, how is it going to feel? It's going to feel soft, more pliable, right, underneath your fingers. If it has a lot of blood vessels in it, how is that going to feel? Fluctuant, squishy, okay? It's going to feel different. So the stroma that's actually supporting this tumor is what determines how it's going to feel, the consistency of the neoplasm, right? So when you palpate it, how do you feel it? Okay. So then you have a term that's called local invasion. Okay, so local invasion is something that's typical of malignancies, right? So you do not see invasion in a carcinoma in situ. You do not see invasion in a benign tumor. Okay, when they do, so whenever you say local invasion, basically you're looking at, is it infiltrating the adjacent structures? Is it going to a distant structure? Okay, is it destroying the tissue in that area? So for example, if you're looking at a tumor in the jawbone, right, and if it's adjacent to a tooth, okay, what features would you look for to figure out if this is an invading kind of lesion?
Radiograph.
I'm sorry? You take a radiograph, but what features are you looking for in a radiograph to help you?
Does it mean like, does it leak?
Okay, so you have a patient walks into your office, okay, and then they have an expansile lesion in the jawbone, okay. You decide to take a radiograph, okay. You took a panoramic radiograph. Once you took a panoramic radiograph, you noticed at the tip of the root of the tooth, there's a large radiolucency, okay. But then you want to try and figure out by looking at it radiographically, is this something that's an aggressive kind of lesion, or if it's not aggressive, right? If it's infiltrating. So what things can you look for that helps you to tell? Borders is one thing. What else? What impact does it have on the adjacent structures, right? So that means, is it resorbing the tooth root? Is it separating the teeth from each other, right? Is it causing expansion of the cortical bones, okay? Those are all features that helps you to tell if this is an invasive pattern, right? If it's an infiltrating kind of lesion. So same thing you can apply for your soft tissue lesions, okay? You try and see, is this, going into the lymph nodes in the neck? Is it, affecting other organ structures, okay? Is it destroying the tissues in that area where you're seeing this, tumor, okay? So if it's a benign tumor, again, we said they have a capsule. It's really easy to take them out because you have a capsule. They have a less chance of coming back because now you took them out entirely, so the recurrence potential is pretty low, and they grow as an expansile mass, okay? But if it's a malignancy, invasiveness is a critical feature, right? Because that means it broke through the basement membrane and it went into the connective tissue. And invasiveness is a feature that helps you to differentiate a benign tumor from a malignant tumor. Invasiveness helps you to differentiate from a carcinoma in situ versus a carcinoma. Okay? So invasiveness is a critical thing to remember. So if I ask you, what is it that helps you to differentiate as the most reliably from a benign to a malignant tumor with regards to its, behavior, you talk about invasiveness. Okay. Again, malignant tumors usually don't have a capsule. They're not well defined. So when you treat it, do you think it's more problematic to treat a malignant tumor? Yes. Why? Because they don't have a capsule, right? They start getting into the adjacent structures. So they can go and affect blood vessels in that area. They can go and infiltrate into the nerve in the area. They can infiltrate into the salivary glands in the area. They can infiltrate the fat in the area, right? So when they do that, it's hard to treat them, right? So whenever you're treating a malignancy, what we usually recommend is take at least a rim of normal tissue around the malignancy, because you want to get clean margins, okay? Because if the margins are positive, that means you have to go back in and then remove whatever is remaining, or if you leave it the way it is, then it's going to come back, it's going to recur.
So
Yes.
that's like when you get a mole removed and they take way more than they need to, because they're just making sure to find a normalcy around it.
Exactly.
Compare it to.
So you always want to get normal tissue. So some tumors you treat a little bit more aggressively. So for example, if you look at a melanoma, right? It's a much more aggressive, tumor compared to like a mole, a macule, right? So in melanomas, obviously the amount of normal structure that you take around is going to be much wider than what you would in case of a benign lesion, okay? Because you want to make sure that, you're clear of the tumor all around. Yes?
And if that mole was to grow back, then that would be a sign that you have to get more of it removed.
Yes. So moles typically don't transform into melanomas, okay? But there's different type of pigmented lesions. So you have what's called, like the melanotic macules, okay, which are your, similar to your freckles, okay? Those typically don't turn into melanomas. But there's another type of, when you use the term mole, typically what we mean is it's a nevus. Okay, so there's a difference between a freckle and a nevus. So mole typically means it's a nevus. So nevi have the ability to transform into melanoma. Okay, not every nevus transforms into a melanoma. If a patient, so don't worry about if you guys have moles on your face and body, because if there's multiples of them, right? So it has to be usually in hundreds. That increases the risk for that mole to transform into a melanoma. Okay, but that's something. Nevi are a little bit. The behavior is a little different from a freckle. When we say mole, we're talking about nevi basically. Okay, so even though they can all look the same, like brown pigmented lesions. Okay, so another characteristic of neoplasm, the first characteristic we said was invasiveness, was critical. The other thing is metastasis. Because have you guys heard of TNM staging for cancers? Okay, so anytime you have a malignancy, they do what's called staging of the malignancy. So they basically tell you if it's a stage 1 tumor, stage 2, stage 3, stage 4. Why? Why is that important, knowing the stage? So the higher the stage, the prognosis is going to change significantly, and the way you treat it is going to change, right? So for example, if you have a patient who has squamous cell carcinoma, so in the mouth, right? If you diagnose it as a stage 1, at 5 years, the ability to survive that disease for a patient is maybe 70 or 80%. But if you diagnose it as a stage 4, what do you think the prognosis is? 5-year survival rate? It's about 30%. So it drops 50% almost by not diagnosing it early enough. And that's why we emphasize that please do a thorough intraoral examination for every patient of yours. You guys are basically the first barrier, right? You have to make sure that you do a thorough assessment. In extraoral and intraoral, because if you can diagnose a squamous cell carcinoma in its early stages, it significantly improves a patient's 5-year survival rate. Okay, so we play a big role as dentists, because physicians unfortunately don't look in patients' mouth. Okay, that's the last place that they want to look in, and even if they do, they have no clue what they're looking at. Okay, my husband texts me all the time. He's like, okay, how do I treat herpes? He's like you're a physician, you should know, But unfortunately, because, that's not their area of expertise, and they just don't want to deal with it. So it's critical to figure out if it's metastasized or not, right? So when you talk about metastasis, what we're trying to say is, you have these neoplastic cells, right? So the tumor cells, they basically went to a different part of the body other than where it's supposed to be, where the primary tumor is, right? So, and then when they move to a different site in the body, they basically, nicely get settled in that area, okay? And then they establish their site there, okay? So that tumor, so the process is called metastasis, and that tumor where you see at a site that's different from the original site is called metastatic tumor. Okay, and typically benign tumors don't metastasize. There are some exceptions to that rule, but we won't go into that. So the general rule is benign tumors don't metastasize. Okay, so how do they metastasize? Yes?
I just have a question. So when it moves, it's called the metastatic tumor?
Yeah, so the process is called metastasis. So the process, how it moves from the site where the original tumor is to a distant site, that process is called metastasis. And once it goes to the distant site, and so for example, it went into the lungs, right? And then it formed a tumor in the lungs, that tumor is called metastatic tumor. Okay? This is your primary tumor in the jaw, and this is your metastatic tumor in the lungs. Okay, so you don't use the term primary tumor here because it didn't arise from lungs. It originated in the jawbone, but it went through the bloodstream, went into the patient's lung, and basically patient developed metastasis there. So this is metastatic tumor.
Okay, because sometimes patients might be, seeing a physician, right, for their routine checkup. And then, they may, notice something that is abnormal. And they may, do some imaging. And then they realize, oh, there's some tumor here. And then they decide to biopsy it. But then that tissue that they biopsy from this metastatic tumor is not going to look like lung tissue, right? Because it originated from the jawbones. And then they start hunting for where did it arise from. Okay, and then they start doing further tests. So when you have metastasis, there's different routes that a tumor can metastasize. One is called seeding within body cavities. Okay, a good example for these are ovarian cancers. So if there's a malignancy in the ovaries, what it does is it actually, the tumor, the way it spreads is it invades the body cavities. Okay, so a tumor that arises in an ovary, basically what it does is the way it spreads or metastasizes is by a process called seeding. So it goes through the body cavity and then it establishes at a different site in the abdomen. Okay, so that's called spread by seeding. Then there's a different kind of spread that's called hematogenous spread. What does hematogenous mean? Through the blood, right? So you can spread by seeding, so that means it just goes through the body cavity and then just sits on the peritoneum, in the abdominal area. That's one way. The other way, which is the more common way, is the hematogenous spread, right? So it goes through the bloodstream. When it goes through the bloodstream, remember it goes to the lungs and liver, okay? Because all caval blood flows to the lungs and all portal drainage goes to the liver. And you guys talked about this, right? So lung and liver are the most common sites by hematogenous spread or through blood that can metastasize. Two common sites are lung and liver. And usually sarcomas, so it's a type of malignancy that arises from connective tissue. When I use the word sarcoma, it means it's a malignancy that arises from connective tissue. Okay, those tend to spread by through blood. Then you have a lymphatic spread. Okay, lymphatic spread are more common in carcinomas. So carcinomas means they arise from epithelial cells. Okay, and the pattern in which the lymph nodes get involved depends on where this neoplasm drains into, which part of the what is the drainage pathway into the lymphatics. So for example, sometimes what can happen is the cancer cells, when they go through lymphatic channels, they can skip a lymph node, okay, that's right next to it, and then they go and get trapped in a different lymph node. So that's why when you do a head and neck examination, you have to make sure that you're looking at all the different areas, because there's different levels of lymph nodes. You guys know that, right? So in the, so anterior to sternocleidomastoid, posterior to sternocleidomastoid, you have different levels of lymph nodes, and each level you have to make sure that you palpate it, because occasionally what can happen is a tumor that's in the mouth can metastasize to the lymph nodes, but it may not go to the one that you think it would go directly. It may skip it and then go to a different lymph node. Okay, so it's critical to make sure that you do a thorough head and neck exam. Okay, so when it skips like that, it's called skip metastasis. So that means it didn't go to its immediate site, but it went to a different site. Okay, so most malignancies spread either through blood or through lymphatics. Okay, so it's either hematogenous spread or lymphatic spread. As I said, the seeding one is very limited. It's, that's not something that's very common. Okay, so this is actually an example of a liver that had metastatic cancer. Okay, so where is all the metastasis? What do you guys think is the metastasis? Yeah, so these are all metastatic deposits right there. All of those yellow-white things that you're seeing in the liver is metastasis. Okay, so and it's very common, as we said, liver and lungs are the two common sites that things metastasize to. Okay, so let me kind of summarize really quickly, and then we'll move on to nomenclature. So we talked about different terms. So we talked about
hyperplasia. What does hyperplasia mean? Increase in number of cells. What does hypertrophy mean? Increase in cell size. What does dysplasia mean?
Different.
Disorderly growth, right? Are there different grades to dysplasia?
Yes.
What are the different grades?
Grade 1 is in the bottom 30%.
Mild, severe.
In-situ.
So if you see mild, what part of the epithelium is affected? Lower 1/3. If it's moderate, half of the epithelial thickness. If it's severe, 2/3. If the entire epithelial thickness is affected,
Carcinoma in-situ.
carcinoma in situ. And what is the critical feature of carcinoma in situ?
It does not break.
Lack of invasion. That's the main thing, lack of invasion. If it invaded, what would you call it?
Squamous cell.
Carcinoma, right? If it invades, it's carcinoma, it's a malignancy. What does the term neoplasia mean?
Tumor.
New growth, right? But the kind of growth that you have is, it affects not only the cellular structure, but it also causes increased proliferation of the cells, right? And if that new growth forms a mass, what do you call that mass? Neoplasm. What are the different kinds of neoplasm? Benign and malignant, right? How do you differentiate between a benign and a malignant neoplasm? What critical features do you look for? Whether it's capsulated or not? Is it localized or not?
Differentiation from original tissue.
Differentiation from the site, the tissue that it originates from. Does it spread? So does it metastasize or not? If it metastasizes, what would you call it? Malignant. Okay. There's something else. Mitotic figures. So mitotic figures. Does it have mitotic figures or doesn't it? Does it lack the mitotic figures? Okay. Then we talked about if you have a neoplasm. What is the components of the neoplasm? What are the two areas?
The parenchyma
Parenchyma and stroma, right? So what does parenchyma contain? The tumor cells, right? And what does the stroma contain?
vessels.
The supporting tissue, right? And what is the supporting tissue is made up of?
Blood vessels.
Blood vessels, and it can also have inflammatory cells along with blood vessels, okay? And then what are the other characteristic features of a malignancy? Things that you have to, that tell you that this is malignant is invasiveness and metastatic potential, right? What does invasiveness mean?
The migration into other tissues.
The impact that it has on adjacent structures, right? So does it have the ability to infiltrate? What kind of damage does it have, on the adjacent structures? Okay, so those are critical things. And then you need to know about differentiation. So critical things are differentiation, invasiveness, and metastatic potential. So differentiation can be well differentiated, moderately differentiated, poorly differentiated, or anaplastic tumors with no differentiation. Okay, so when you look at nomenclature, right, and this is when you come across the different tumor names, this is how they come about, the names, okay, and this will kind of give you a clue. So the prefix of the name of a tumor depends on the cell or the tissue from which originates. So if it arises from fat, what would you call it? Lipoma, okay, because lipoblasts are cells, are fat cells, okay. Oma basically means it's a tumor, okay. So oma, if it ends with the suffix oma, then you're saying that it's a tumor. If it arises from fat, you call it lipoma. If it arises from nerve, neuroma. Neuroma is reactive in origin. That's a little tricky. Okay. How about smooth muscle?
Sarcoma.
No, sarcoma indicates malignancy. If it's a benign lesion, we call it oma, right? We said oma is the suffix.
Myoma.
Leiomyoma. So it's smooth muscle in origin. What is skeletal muscle? Rhabdomyoma, because it's made up of rhabdomyoblasts. Okay, so if it's smooth muscle in origin, you call it leiomyoma. Skeletal muscle in origin, it's rhabdomyoma. There's actually a table in your handout that gives you the tissue of origin and then the name that goes along with it. Okay, so anytime, I'm sorry?
We have to know all of them.
You don't have to know all of them. I'll tell you what you need to know once we get to the table. So The term oma basically means it's a tumor, okay? Typically, oma, benign tumors ends with just the suffix oma. If it's a malignancy, they end with either carcinoma or sarcoma. So they have carci or sarc before the oma, okay? If it's carcinoma, that means we know it's a malignancy that arises from epithelial cells. If it's a sarcoma, it's a malignancy that arises from connective tissue components. So it could be nerve origin, it could be muscle origin, it could be blood vessel origin. All of them would be called sarcoma because they're all connective tissue components. And carcinomas are much more common than sarcomas. There are a couple of exceptions to the rule of omas. Because remember we said oma is benign, but there are a few exceptions, and I'll talk about it. Yes?
So then you say sarcoma and what was it?
Carcinoma. So sarcoma means it's a connective tissue origin. It's a malignancy that's connective tissue origin. Carcinoma means it's a malignancy that's epithelium in origin. Okay? But if it just ends with the term oma, then it's a benign tumor, typically. Except there are exceptions, and we'll talk about that. What is a hamartoma? The word hamartoma. Hamartoma basically means you have a mass and it's really disorganized, but then it's native to that site. So for example, have you guys heard of the term odontomas? They're teeth-like structures that you can see in the jawbone, okay? But they're not teeth, so they don't have the organization of a teeth. But if you took a biopsy of it, look under the microscope, it'll have enamel, dentin, pulp, all of it, right? But it's just really disorganized. So it's a hamartoma. So that means it has all the elements of normal structures, but those elements, they're not organized well. They're all disorganized, okay? But then they are in the jawbones, right? So that means they're in a site that they should normally be, okay? So that's why they call them hamartoma. The term choristoma, for example, means you have this disorganized, you have this mass, it's made up of this tissue, but that mass does not belong to the area where you see it. So for example, if you saw bone on the tongue, is that normal?
No.
If you see cartilage on the tongue, is that normal?
No.
No. So what do we call them? Choristomas. So if I saw bone on the tongue, I call it osseous choristoma, because osseous means bone, okay? If I see cartilage on the tongue, I call it cartilaginous choristoma, because you can get those sometimes on the tongue or other sites in the mouth. So that's why understanding terminology is extremely important, because that's the only way we can communicate. Like if I say lipoma, you all know that it's a fat tumor, right? I don't have to explain further. Yes.
Would tori be considered that, or is that just like a genetic?
So tori is actually a developmental abnormality. It has a couple of reasons why you see that. There can be environmental and a genetic component to it. So tori is not something you would consider, as a hamartoma. Someone else had a question?
I didn't. I was going to ask, are these developmental?
No. Okay, so the things that you need to know is you need to know epithelial in origin, because you're going to see these things in patients. Papillomas, right? If you see the term squamous papilloma, that indicates that it's epithelial in origin. Okay, oma, benign. And what's the malignant counterpart? Is squamous cell carcinoma. So squamous cells, you should know those names. What is the benign one and what is the malignant one? Okay? You just need to know adenoma and adenocarcinoma if it's from the glands or ducts. You don't have to know the cystadenoma. If it's melanin, right? If it's melanocytes, remember I said nevus, that's your mole, and then the malignancy is the melanoma. Okay? But melanoma is ending with the term oma. Does that mean it's benign?
No.
No, this is an exception. Okay? Melanoma, even though it ends with the term oma, it is not a benign lesion. This is extremely aggressive. It can kill the patient. The mortality rate is high, especially when they have lesions, melanomas in the oral cavity. The extremely aggressive lesions. Please do not ever think that melanoma is a benign lesion. Okay, it's a malignancy. So you need to know nevus and melanoma. Okay, so then the common things with connective tissue are fibroma. You don't need to know the malignancies for connective tissue. Just know that if you have fibroma,
If it's a malignancy, it's a fibrosarcoma. You just add sarcoma to it, and that's it. That becomes the malignancy. If it's cartilage, you don't need to know cartilage. You need to know bone, because there are some syndromes where you can actually see these osteomas form. So please know that bone, it's called an osteoma, the benign one. Fat, it's very easy to remember. So we're going to talk about hemangiomas and lymphangiomas in soft tissue tumors. So you need to know those terms. Okay, you don't need to know the malignancies though. You don't need to know meningioma. And then blood, this is important. So hematopoietic, if it's blood vessel origin, blood cell origin, then you call it leukemia. Okay, so leukemias and lymphomas are again exception to that OMA rule. They're also malignancies, but they don't. So lymphoma ends with the term OMA, but it's a malignancy. Okay, leukemia does not have any OMA in it, but it's a malignancy. Okay, so you need to know that. Just know the smooth muscle and skeletal muscle. The rest you don't need to know. Okay, but this is a good list for you guys to have. So in future, if you ever come across a patient who tells you that I had this disease, then you know what they're talking about. What is the site of origin? Okay, this one you should know. Salivary glands. A benign neoplasm of salivary glands. You can use the term pleomorphic adenoma. There's many other benign tumors. We're just using the one that's most common. So here, if you look at it, actually on the top, I don't think I showed you this one. If you look on the top here of the table, it says one parenchymal cell type, right? So when you say papilloma, it basically is arising only from squamous cells, epithelial cells. When you say fibroma, it's only from fibrous tissue, right? Osteoma, it's only from bone. So there's only one cell type. But sometimes some tumors can have more than one cell type in it. Okay? An example for that is pleomorphic adenoma. So this is a benign tumor of salivary glands, but if you took a biopsy of it, I'm going to see cells that look epithelial. I'm going to see cells that look cartilaginous. I can see cells that look like fat with cells that look like bone. A lot of things can be seen in that tumor. That's why it's called pleomorphic. So you have multiple presentations to it. Okay, and it's an adenoma. And if it's a malignancy, you just comparable to pleomorphic adenoma is called malignant mixed tumor. You don't need to know the other two. Okay, so let's quickly look at this and then we'll stop. Okay, so this is a pleomorphic adenoma, and this is what I mean by how it can have multiple presentations. So this area that you're seeing right here, that looks like cartilage. Okay, these cells that you see here, they are more epithelial, plasmacytoid cells. Okay, and then you have this fibrous connective tissue in between and areas that look like bone. Okay, so this has all three components: epithelial component, a bone component, and a cartilaginous component. So there's more than one cell type that gave rise to this tumor. Okay, so this is a mixed tumor. And this is what they look like clinically, right? So they look like these expansile masses. The most common site for pleomorphic adenoma is actually the heart palate. But that's something you have to, when you get to salivary gland pathology, you'll kind of know. So this is the malignant counterpart of the pleomorphic adenoma. So a pleomorphic adenoma occasionally can transform into a malignancy. Okay, so it can start off like this one here, and then, it can transform into this. Okay, so this is a malignancy that can arise in a pleomorphic adenoma. Okay, and then sometimes you can have more than one cell type, but it also arises from more than one germ cell layer, and then you call those teratomas. Okay, so if you have multiple germ cell layers that the lesion is arising from, you call them teratomas. Okay, so let's stop right here, and then we'll continue on Monday. Do you guys have any questions? Yes.
I have a question. You were talking about the hemorrhages, the ones that have enamel and everything like a tooth.
Hold on.
Where is that in the mouth? Where is that in the mouth?
In the mouth? So you usually see them in the maxilla or mandible.
So there's two different types of odontomas. So you can you have a compound and a complex. A compound odontoma tends to be more common in the anterior maxilla. A complex odontoma tends to be more common in the posterior maxilla. So they'll sit on top of the tooth or in between teeth. But then they prevent sometimes they could be you can have
Alright, so what time is it?
Let's go right now.
About to go home?
Huh? Yeah, I have to go home.
Alright,
I'm heading over right now.
alright,
Alright,
so
thank you.